Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Thank you all for joining us for today's podcast titled Hallucinations in the Night. Hallucinations occurring during the night may be deeply frightening, suggesting to those that are experiencing them that they may be developing a sinister psychiatric disorder. But there are more often other causes that are benign. To discuss sleep-related hallucinations, my guest today is Dr. Michael Silber, a professor of neurology at Mayo Clinic and a board-certified neurologist and sleep specialist. Mike, thank you for joining us today. Let us start with the most recognized sleep-related hallucinations, those that occur at sleep onset or hypnagogic hallucinations, and those that occur upon awakening in the morning or from a nap, known as hypnopompic hallucinations. How common are these, and are they always associated with narcolepsy?
Well, thank you. These hallucinations are really very common indeed. They're most often visual. They can be fairly elementary shapes or lights, or they can be more complex in some ways, sometimes vague figures and images. They can be auditory, sometimes sounds, though not usually particularly speech. They can sometimes be odd hallucinations, tactile ones like insects crawling on the skin, and occasionally they may be out-of-body experiences. They are common. Studies have shown that about 25% of people will report hypnagogic hallucinations of some kind or some sort of imagery they perceive at sleep onset. Sleep offset, the hypnopompic ones are less common. Probably about 7% of the population will report them. And it's often very hard to differentiate true sleep offset hallucinations from simply waking up during REM sleep with a dream that seems to persist for a little while. Sometimes these hallucinations are associated with sleep paralysis. More often they are not. Now, we classically think of these hallucinations as associated with narcolepsy, and in fact, they are both part of the so-called narcolepsy tetrad: sleepiness, cataplexy, hypnagogic hallucinations, and sleep paralysis. But that concept has fallen into disrepute because of how common they are in the normal population. They're especially common in younger people, adolescents, and people in their 20s, and can be very frightening to them if they don't know what it really is. I recall one patient who was terrified. She was lying in bed facing the wall, and she suddenly became aware of a presence of some sort in her room, and the presence was slowly pulling the bedclothes off her bed, and she couldn't move. And I mean, devastatingly terrifying. And then she was eventually able to move. And of course, there was no presence there at all. And she thought she had some sort of vision or psychic experience, but a not untypical, frightening hypnagogic hallucination. In narcolepsy, type 1, these hallucinations are common. About 60% will describe it. Narcolepsy type 2 less, probably not more than the general population. Often, again, associated with sleep paralysis, so they're not specific. And certainly when a patient presents to us with a young person with hallucinations and there's no history of sleepiness, we should reassure them that the chances they've got narcolepsy is extremely low. It's probably just a normal phenomenon, and they tend to disappear with age, and generally reassurance is sufficient for this type of hallucination.
Very helpful. So I think perhaps now we should talk about a somewhat different type of sleep-related hallucination or complex nocturnal visual hallucinations. How are these different? When do these occur? And what are some of the clinical and polysomnographic features of these?
Yes, I think these are different, but the jury's not fully out on that, and some people would say they're variants of hypnagogic hallucinations, but they're different in that they wake patients up in the middle of the night. The first question, of course, is what stage of sleep do they wake them from? And it's really difficult to record these hallucinations. I think I've only managed to do that twice. And they both came out of N2 or early N3 sleep. And a few other reports in the literature suggest, again, they are non-REM phenomenon rather than a REM phenomenon. And that's borne out by the fact that the patients don't generally describe preceding dream imagery. So they wake suddenly in the middle of the night with very vivid visual hallucinations. These are not vague shapes or colors. They'll see people, animals in the room, brightly colored, often distorted, people with half a face or sort of squat people. It's strange, witch-like sometimes, brightly dressed, animals, birds or butterflies fluttering. Generally, they don't move much. So I had one patient who had a butterfly fluttering through her room, and she chased it, and it ended up in a jar on her dresser, and she looked into the jar, and of course there was no butterfly there. But that's unusual. Usually they're relatively still. They usually don't talk, even though they can be frightening to see. They don't talk generally, though sometimes there's accompanying auditory hallucinations, often just a clang or a bang or something rather than a whole lot of speech. And the patients initially are absolutely convinced that these are real. They jump out of bed, and again, this is not sleepwalking. They're fully conscious, they're alert, they jump out of bed to try find or chase away the hallucination, and then after they happen a few times, they realize they're not really real, and they get insight into it. And most patients discover that the best way of managing this is to turn on the light. Because as soon as the light's on, the hallucination inevitably vanishes. So those are the clinical features, and we think when we see them during polysomnography.
Do we know much about what might cause these frightening events at night?
Yes, we know quite a bit. I look at these complex nocturnal visual hallucinations waking people from sleep as a sort of final common pathway for a lot of different conditions. And the general thread that runs through most, though not necessarily all of them, is decreased sensory input into the visual cortex. So let's talk about a few possible causes. And as I'll explain, a lot of them are idiopathic and there aren't any causes. But the first thing we think about is visual loss, because these are very similar to the Charles Bonnet, B-O-N-E-T, hallucinations that people who have fairly marked visual loss experience during drowsiness or in dim light. And sometimes they just wake people up from sleep. So the idea then is that these are called release hallucinations because the visual occipital cortex is released from its normal constant flood of visual information by interference with the visual pathways. And this can be at any level, cataracts, retinal degeneration, common, or back through the chiasm, or even in the visual cortex itself. So anywhere along the visual pathways, as long as it's bilateral and as long as it's moderately severe, you can get these hallucinations forming. Um, so that would be the first thing we'd think about. Do people have Charles Bonnet syndrome? The second thing that we have to at least think about is this type of visual hallucination may be a feature of Lewy body disease, of dementia with Lewy bodies. And I've seen several patients in whom it's the presenting complaint. They don't say they've got cognitive impairment, they start hallucinating, and then you test them, and yes, there's mild cognitive impairment, which progresses. Now, generally in Lewy body disease, the hallucinations occur later, but not always. Sometimes they occur very early in the disorder. So one has to think of cognitive issues, especially when they start for the first time in middle age, older age. Now, there is at least one study from Mayo, actually, a very interesting study, which suggests that patients with Charles Bonnet hallucinations, some of them will go on to develop Lewy body dementia, because you've got to ask the question. There are lots of people with visual impairment in this world, and the majority do not get hallucinations. So it may be the combination sometimes occurs, and you may have to follow those visual impairment patients who have the hallucinations up carefully to see if cognitive impairment develops. So Lewy body disease. And again, thinking of this final common pathway, Lewy body disease does have a predilection for the occipital cortex. So if you're damaging input into the occipital cortex at cortical level, again, decreased input, and again, the cortex fires by itself and generates the hallucinations, maybe a mechanism. Then We also have to consider, does the person actually have narcolepsy? Because hallucinations, as we know, especially the hypnopompic and hypnagogic ones, are associated with narcolepsy, and occasionally they'll have complex nocturnal ones. But then there's always something, there's always the sleepiness. It's not isolated, it's not a first presentation. Then the next thing I think about is drugs. And I've seen several patients on beta blockers in which this is developed. So beta blockers do affect dreaming. They cause more vivid dreaming. They sometimes cause nightmares, and sometimes they can cause hallucinations. So always think of beta blockers, and then also think of people on dopamine agonists. Again, that gets confused with Lewy body disease because the majority of people on dopamine agonists, of course, have Parkinson's disease, but dopamine agonists sometimes can cause this sort of hallucination as well. And then there are others, especially younger people, and these hallucinations can start at any age. I've had people start where it starts in childhood all the way up to older age, especially in younger people who don't have narcolepsy. They're not likely to have blindness or neurodegeneration. In some case, I think anxiety disorder does predispose. Some of my patients with these do have anxiety, and others, it's an idiopathic parasomnia. And sometimes when you ask, they also sleepwalk on occasion and have some other parasomnias, and we don't quite understand that group, but sometimes it's totally idiopathic. Younger person, you don't have to really worry about whether something else is going to develop. The last one I'll just mention for completeness is after acute strokes involving the thalamus generally, one can have a period for several weeks of these vivid hallucinations. This is called peduncular hallucinosis, a bad term because peduncular suggests the cerebral peduncles and the midbrain are involved, and generally the infarct's in the thalamus, which again makes sense in pathophysiology because our thalamus is our big relay center for all sensory input coming in and being taken to the sensory cortex. So again, same mechanisms. So that's really the main causes I think about when I see these patients, and often it's just idiopathic.
So I imagine there are other differential considerations here, right, Mike? With what other conditions might these complex nocturnal visual hallucinations be confused?
Yes, the diagnosis of complex nocturnal visual hallucinations is clinical. We don't usually have to study the patients, and as I said, we very rarely pick them up in the lab, but there are other things you've got to think about. The first would be nightmare disorder, person waking up from a frightening dream. Clearly, that's different. The complex visual hallucinations patients don't describe preceding dreaming. The hallucinations are during wakefulness after waking, and a nightmare patient knows immediately they've woken up from the dream and it's past. So that's one thing to think about. The second, which may be a little more difficult, are sleep terrors. The non-REM arousal parasomnias where the person wakes up and is confused, sits up, looks around, but they're confused. These patients aren't. They straight away know that they're awake, even though they're seeing these hallucinatory experiences. Some patients with sleep terrors or confusional arousals, even though they're non-REM, will describe some imagery preceding it, but usually it's very elementary. The bed's on fire, a big black bell's descending over their head, but it's different. They're confused when they wake up. Then the common condition of REM sleep behavior disorder. But again, that's different. Those patients act out their dreams. They flail, they kick, they talk, they shout while they're still asleep. And if you don't wake them up, they don't remember they've done it. They'll be if you do wake them up, they'll describe frightening dreams of being attacked. But that's very different from these hallucinations. One condition which is not all uncommon is exploding head syndrome, where somebody wakes up in the night and there's with a bang or a painless explosion in their head. But that's it. It's just an ordinary elementary hallucination of little consequence, probably a wake sleep transition parasomnia, very different from these vivid things. Then there are two neurologic conditions we do have to consider. Could the patient be having seizures? Now, when seizures start in the occipital lobe, where our visual cortex is, surprisingly, they're usually elementary hallucinations, flashes of light, colors, not these vivid animals and people. But when they're a little more anterior, coming from the temporo-occipital junction, sometimes they can be vivid hallucinations exactly as I've described, and they can happen during the night. Now, you'd hope they'd also happen during the day to make it easy, but it's not always easy. But the main thing is when it is seizures, it will be stereotyped. Should be the same scene or similar scene happening each time, which doesn't happen with the complex visual hallucinations. And obviously, if you do put the patient in an epilepsy monitoring unit and record an event, you should see seizure discharges with these, if these are seizures. And the last neurologic one is migraine. Some migraine sufferers get complex prodromes rather than just flashing lights or zigzag lines. They can see things like this, very rare, but it can happen. But almost invariably, it will be followed by headaches. So that makes it a lot easier. Complex nocturnal visual hallucination patients don't have headaches. The final differential, which, this is how you started this whole discussion. The patients worry they are developing schizophrenia or some psychosis. Um, Most hallucinations in psychotic illnesses such as schizophrenia or bipolar disorder are auditory. That's much commoner, and usually it's well-formed voices, often telling the person to do things, command hallucinations, but not always, and they can be visual hallucinations, but almost always there are other psychiatric features, there are delusions, there's thought disorder. It's not just isolated hallucinations of this type in a person who in the morning is clearly psychiatrically normal, so it shouldn't be a problem sorting that out.
So, as you've outlined, these hallucinations can obviously be quite distressing for the individuals that are experiencing them. Do we have any treatments for these nocturnal hallucinations?
Well, if one doesn't want to use potentially harmful drugs, there's very little which seems to work. There's some reports of melatonin being helpful, but there are also reports of melatonin causing nightmares, so I'm never been particularly impressed with that. I don't think there's any easy way of treating the more benign ones. I reassure the patient they're harmless. You've not got any other disease if they don't. And, the main thing, switch on the light and they'll go away. And most patients are perfectly satisfied with that. Now, in the setting of Lewy body disease, sometimes as the disease progresses, these hallucinations spread into the daytime as well and can be very disturbing to the patient and the caregiver. And then there are medications which can be used. There's one drug FDA approved specific for Lewy body related hallucinations called pimavanserin, which is a serotonin inverse agonist. I don't treat Lewy body disease outside of sleep medicine. I have one patient on this, and the hallucinations were beautifully controlled, and he's a lot more comfortable on this drug. And then there are the more classic neuroleptic agents, of which quetiapine is the one we're most familiar with. Low-dose quetiapine at night can be very effective in sorting out some of these unpleasant hallucinatory experiences, but these are powerful drugs, and I would restrict them to patients with degenerative disease like Lewy body disease who are very troubled by the hallucinations. I wouldn't treat idiopathic or anxiety-related hallucinations with these powerful drugs.
Very helpful. Mike, thank you for sharing your expertise in this area. Are there any final messages that you would like to leave with our listeners today?
Well, firstly, hypnagogic and hypnopompic hallucinations are common, generally benign. You can diagnose these complex nocturnal visual hallucinations by a careful history and easily separate them out from other conditions. You have to look for visual impairment, Lewy body disease, drugs such as beta blockers, but often they're idiopathic, sometimes anxiety-related hallucinations. Usually reassurance is what you need, and generally remembering, turn on the light, and they tend to vanish away. So thank you for inviting me today.
Thank you for being here, and thank you to our listeners for joining us today.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.